have all the other members to, in the interest of time, if you could do your introductions in the chat today, we would definitely appreciate that. Um, and then I'm going to turn this over to Anne to start our roll call. Thanks, Anne.
Right. Liz. Kim Bartholomew. Alana Braun.
Yep, here today. Thank you.
Lisa Chambliss.
And she is here. This is Jenny. She just wrote in chat that she doesn't have a mic, but Lisa is here.
Clarice Charging.
Here.
Paul Cieslak.
I'm here.
Erin Corrigan.
I'm here.
Jason Daniels. Stacy Diassis Matthews.
Hello.
Teresa Everson. Barbara Fisher. Tara Gardner Brown, we just met you, so I'll check you off. Jen Gibbons.
I'm here.
Jessica Gonzalez. Brian Gooden. Holly Groom.
I'm here.
Tim Hall. Amy Kirkbride. Rex Larson.
Here.
Mimi's here. London Manor Peterson. Kelly McDonald.
I'm here.
Jenny McKibben.
I am here.
Joanne Rogovoy. Deborah Rumsey.
I'm here. Thank you.
Gary Runyon. Molly Sachs.
Here.
Becky Sherman. Danielle Sobel.
Here.
Shelby Thompson. I see London just popped in, so let me go check her out. Amanda Timmons. She's coming, I know she's on her way. Dee Weston. Colette Young. Angela Zollin.
Here.
Christy Zamora Polanco. All right, how's everyone?
She's here, and
Oh,
I can
see,
see her in the list.
Yeah. All right. We are done. Thank you, everyone.
Thank you, Anne. And thanks everybody for putting your introductions in the chat too. We really appreciate that. Next up is public comment, but we didn't get any this month. So I'm going to move on to Rex Larson for some high-level metrics and recent outbreaks. Rex, are you ready to roll?
I am ready to roll. Give me 1 second to share my screen.
Rex, don't forget to introduce yourself.
I will introduce myself.
Okay.
Okay, can everybody see my screen?
Yes.
Okay, wonderful. I'm Rex Larson. I'm the Surveillance and Quality Manager with the Immunization Program. I have spoken with IPAT many times before, and I know many of you. Really happy to be talking with you again today. I'm going to be giving kind of the annual immunization rate update. I'm going to talk about some, as Julie said, high-level immunization rates, the trends that are happening in Oregon, what are the new developments, a bit about some of the outbreaks and sort of disease incidents that we've seen this year, and then to talk a bit about how Oregon can shore up our immunization infrastructure. So what are we going to talk about today? How are immunizations going in Oregon? Immunization rates across the state. I'm going to get a chance to show you some of our dashboards, childhood, adolescent, and seasonal vaccination dashboards, and also to talk a bit about our outbreaks and disease, and as I said, a bit about shoring up immunization infrastructure. It's going to be pretty exciting. I think many of you probably have seen some of our dashboards, but we've had a lot of work on them in the past few years, in particular this last year. So we have some really amazing data available at the county and now zip code level as well. I'm not going to kind of dive into the dashboards in full, but I'd love for you all to kind of, after this meeting, go look at our Tableau website, take a moment to explore, figure out what the dashboards might have that could serve you in your community. So that's kind of where I'll leave that. I have directions at the end of the presentation for how to access our Tableau dashboards if you're interested. And of course, if people have any questions, they're welcome to email me. So starting with childhood immunizations, I think many of you are familiar with the struggles that we've been having. The 4313314, which is really the core set of immunizations that all children should get before they turn 2, had been steady for many years throughout the pandemic, but it was in decline. So sort of after 2021, it began to drop. And we're now seeing that the rates have regressed to 2017 levels. It's concerning because that's a big contrast from the trend from 2013 to 2019, where rates increased by about 10 percentage points across the state. It's a significant trend to reverse, despite investment from the CCO incentive metric and other statewide metrics. I think it's important to pay attention to this. This is going to be a big struggle in the coming years. I think just figuring out ways to address and reverse that declining trend now, hopefully get back to a point where we're seeing an increasing trend. And then, of course, we have persistent disparities that have been around for many years by race and ethnicity. Black, African American, Native Hawaiian, Pacific Islander, and American Indian, Alaska Native children have rates that are 5 to 10 percentage points lower than other groups. So here's the 4313314 rates on the left-hand side. That's the yellow column, and then you can see the individual vaccination rates by year over the years in all the different colors on the right. So the decline is really a slow and steady decline in all vaccination rather than any significant point drop for any single vaccine. So this could, of course, reflect difficulty accessing vaccines due to healthcare capacity issues, which we have seen significantly increased capacity issues since COVID. It also, of course, can reflect sort of changing cultural issues around immunization hesitancy. So I think it's always important to look at these and view them in context. Of course, as I said, that trend is concerning because it was the reversal of a long-standing increasing trend. And then here's kind of the historic data going back to 2014. You can see the significant increases in immunization rates from really it started in 2013, but 2013 to 2019 saw significant changes. Here's our 2-year-old vaccination rates by county. I think it's important to note that we do have obviously some urban and rural disparities that you can see, but the declines in immunization rate are not limited to just one sort of region of the state. So Multnomah County has seen a decline of almost 10% in some metrics, just as many other counties have as well. So I think it's important to note that yes, we still have urban rural disparities in the state, but immunization rates are declining throughout the state. So I think as you look at the map, you can see that there's a large variety of immunization rates in many different counties. Some rural counties, Malheur County, for example, obviously has been able to maintain high rates. And then other counties, we see significant drops. Lake, for example, is one of those counties. And then also, we just got up our vaccination rates by zip code. So I think this is hopefully going to be really exciting for some people. These zip code rates are going to be really useful for targeting interventions, particularly at the local public health department level, where LPHAs have been wanting this data for quite some time. This is just kind of a screenshot of the map feature. You can select your own county and bring up the county and all of the zip codes within it. And it'll give you a summary and county overview, as well as obviously the rates by the zip code. So I'd encourage you all to go explore it. It's very important. A lot of this work is tied to several different sort of accountability and incentive metrics, as I've said. So the Public Health Advisory Board accountability metric of 2-year-old immunization rates this year. And so this should be in use by many different counties for identifying regions where interventions might be used to increase rates. So shifting track to adolescent immunizations. Adolescent immunizations are actually holding steady. So we don't see the same sort of drop that we do for 2-year-olds. Much of that is because there are not nearly as many immunizations recommended during adolescence. And for example, Tdap is required by school law for attendance, so it tends to be a very stable metric. But we haven't seen a drop in either MCV or HPV completion. They've been holding steady for the past few years as well. The big mover with adolescent immunization rates has been adolescent influenza. So adolescent influenza is considerably lower than any other vaccine, and flu rates dropped quite substantially between 2021 and 2022. And we really look at adolescent rates for both 13-year-olds and 13 to 17-year-olds, and the rates dropped for both of those groups, about the same amount. And that trend is actually true for many different age groups as well. So seasonal influenza has taken a big hit. You can see flu in the orange here, about a 10 percentage point, 9 to 10 percentage point drop for flu. Many of the other rates are holding relatively steady. There is some sort of annual fluctuation, but they are maintaining relatively stable numbers. And then this is for 13 to 17-year-olds, and you can see that there's actually been some increases in HPV completion, for example, for 13 to 17-year-olds. And then this is adolescent rates at the county level, sort of that map. We really look at HPV completion whenever we map out geography. Tdap is school required and is quite consistent throughout the state. MCDV doesn't have nearly as much variation, and HPV really is the limiting immunization when we talk about adolescent immunization rates. And significant disparities in HPV vaccination are still seen across the state. Urban regions do trend a bit higher, but we have many rural regions that have focused extensively on HPV vaccination improvement in the past. And we continue to see that those regions have high immunization rates. So I think it's important to note that this is one of those things that a strong provider recommendation and a robust sort of quality improvement project can have a big difference, can make a big difference. I tend to use the example of Malheur County and Klamath County and Jefferson County to demonstrate this. Malheur County Snake River Pediatrics has a practice in it that won the Immunization Champion Award a few years ago. They are incredible immunization champions and have worked quite a bit on improving HPV rates. And you can really see that as far as rural counties go, they have quite a high completion rate. Klamath County has a strong and robust provider network that has worked quite a bit on immunization quality improvement. And I know that Children's Clinic of Klamath, Dr. Cherry, has recently become involved also in some of our media campaigns, working with local media to promote immunization. So I think that's another example. And then Jefferson County, the Warm Springs Health and Wellness Center has worked extensively on improving HPV rates as well. So this is definitely a modifiable thing. And I think a lot of the work that has been happening really is one of the reasons why we see rates holding steady for adolescent vaccination, in particular for HPV. And so hopefully we can continue to invest in that and continue to see that trend. Seasonal immunizations, seasonal influenza rates have been among the most disrupted in recent years. We've seen a significant drop with about a 6 percentage point drop from the 2020-2021 season. This season is likely to close with overall flu vaccination rates under 30% for all ages. Obviously, different age groups will have significantly different impact. Luckily, the 65 plus age group, which is one of our highest risk age groups, is holding a bit more steady and hasn't seen that same decline. But this is a concerning trend that is going to require a lot of work to reverse as well. And then COVID vaccine uptake for the fall 2024 vaccine is pretty slow with low rates for most ages. 29% of adults 65 and over have gotten the fall 24 vaccine at this point. We are hitting a point in the next few weeks, probably not later than early January, where we have adequate COVID supply to meet all of the need in the state. And so at that point, we usually see immunization drop off pretty quickly. We've certainly seen some of it tail off already. Here's seasonal flu rates for the past few completed seasons. It's important to note that the 2024-2025 season data, this is for a partial season, so that 23.7% is going to continue to increase. But as you'll see in the next slide, it's probably not going to increase up above, that 30%. You can see the sort of the shape of the flu season by week, that we're really in that declining period when you look at the data on that tail end, sort of December in the 2024-2025 season, that the green line, it's already dropped quite a bit. And so sometimes we do get a late season bump. If we do get that this season, it probably will not be enough to catch us up to prior seasons. And then this is the fall 24 COVID vaccine rollout. You can see it has declined significantly since the initial vaccination rollout. I think we knew that that would happen. And I certainly know that the hope was that we could at least keep vaccination rates for older adults and vulnerable populations up. At this point, it does not look like we're going to approach anywhere near what we had for those previous vaccines. I think at this season we are, for some of the age groups, looking at data that is comparable to last season's rollout. So it's not a huge drop, but I think it's important to note that there's a lot of room for improvement, particularly for vulnerable adults in this. All that being said, we obviously have also seen some outbreaks and disease increases. Earlier this year, I'm sure you're all aware that we had our largest measles outbreak since 1991 with a total of 31 cases. MMR rates have not fallen very significantly at the state level, but any drop in close-knit communities can have a real disproportionate impact on diseases like measles, where the spread is often in these very close-knit communities. The immunization rates of the county or even the zip code might really hide some of these disparities. And so some of these communities, they may not be visible in our data. I think it's really important to note that local public health departments rely on local knowledge and partnerships with community-based organizations to really identify and work with these communities. So there is a difficulty when addressing these sorts of outbreaks. And then similar things can be said for pertussis. So pertussis is on the rise in 2024. We've had more than 900 cases identified so far, and I think we just surpassed the 2012 sort of high water mark. This will be the most cases we've had in a year since 1953. So certainly concerning. One thing to note whenever we're talking about these disease outbreaks is that they can be difficult to tie back directly to vaccination rates. For instance, with pertussis, there is a cyclical sort of period of outbreak that happens every few years, and COVID sort of disrupted that. So we sort of knew that there was a pertussis epidemic year coming. And the age groups that we see getting sick, nearly 40% of the pertussis cases this year have occurred among adolescents, a group which we have not seen really significant declines in pertussis vaccination for. So I think it's important that we really focus on the vaccination metrics that represent the most vulnerable. And the one that I'd like to sort of pull out is that among the 77 infant cases we've had this year, only 11 mothers were documented to have received the recommended dose of Tdap during pregnancy. So that is something that's modifiable. That's a rate that is really directly tied to our pertussis outcomes, since it really is those smallest infants which are at the greatest risk for pertussis. Here's just the pertussis by year. You can see that we've had a big drop during the pandemic where we had social isolation and we had some school closures and things like that, but we've now rebounded. And as I said, the most since any year since 1953. So I know that I'm running out of time. I just got the 1-minute warning from Julie. So I just wanted to end talking about shoring up immunization infrastructure. I think that what we're seeing is, as I said, the reversal of a decade-long trend of increasing immunization rates in Oregon, disrupted by the pandemic. And I think it's really time to focus on shoring up our infrastructure. We are already working to do that on many different levels. To maintain state-level accountability and incentive metrics. That includes coordinating care organization incentive metrics for 2-year-olds and adolescents. The Public Health Advisory Board just added a 2-year-old accountability metric, as well as an influenza vaccination for older adults metric. And then there is a state health improvement plan priority for 2-year-olds. And I don't want to pretend like these metrics stand alone as any real improvement, but each of these metrics represents hundreds, thousands of hours of investment by clinics working to call kids in and get them up to date, by local public health departments partnering with community-based organizations, looking at their data, identifying specific groups, working with long-term care facilities to bring up influenza vaccination for older adults. So I think it's important to note that these are a key part of our immunization infrastructure. Other work that's happening is the vaccine finance reform work that is underway that Kelly is really partnering with, and we have that steering committee that have been leading. I think that's really critical to make sure that we address the access side of things. And you can't ensure that the differences you're looking at really are due to changes in vaccine hesitancy if you still have access issues around the state like we do. And then, of course, there's a lot of vaccine communications work with local media and provider champions. I mentioned Dr. Cherry, our new communication manager, Raz, is working very hard to sort of implement some of these throughout the state to work in areas where we know that we have growing vaccine hesitancy or we have issues that we need to address. And then I think I just wanted to leave with a question for IPAT. Sort of what are other ways that Oregon can shore up immunization infrastructure in the face of the challenges of the present? And without getting into, obviously, the future, how can we prepare for an uncertain future for immunizations? We know that the coming years are going to be one of struggle, and we know that there is significant investment that can be made to shore up infrastructure now. And how can IPAT be part of that? And how can each member do that in their community? I think that's all I have today. Thank you all so much. And I don't know, Julie, do I have time for questions if people have them, or should we save that for later on?
Yeah, I want to save that for later just because we have such a packed agenda and we're over a couple minutes. So I'm gonna move on, but that was wonderful. Always, as always, Rex. Thank you so much for that. If we catch up and we have more time, then we'll get more time for questions. So we shall see. But thank you. If anybody has questions, you can always email and we can get back to you or put it in the chat as well. But hopefully we will have time in this meeting to get to those. All right, next up is for schools and childcare centers, Stacy Daces Matthews. Are you ready to go, Stacy?
I am ready. So, hi everyone. My name is Stacy Daces Matthews, and let me see here. I don't have anything to share. So I was just gonna talk a little bit about school immunization and what's going on this year. So, Julie, can you let me know how much time I have?
Yes, ma'am. I'm putting a timer on for you for 15 minutes starting right now.
Sounds good. Okay. So I'm the school immunization coordinator at the Oregon Immunization Program, and I use she, her pronouns. I'm also on the policy team. And I want to talk a little bit about the state of school immunization law. So we are at the time of year where things start to get busy for our schools and childcares. These sites submit their immunization reports to their local health departments in January, and then letters are sent to families in advance of the deadline that falls on the third Wednesday each February, by which all kids have to have updated documentation of immunization or exemption. And then there's actually a follow-up report that schools turn in with their most complete numbers, accounting for all the updates that they get in response to those letters. And that occurs in March. So it's a really busy time in the winter for schools, childcares, and local public health. This school year is really business as usual with all the work that comes along with it, like clinics really ramping up vaccination services to make sure kids can get in for immunizations before that deadline in February. But I wanted to talk to you a little bit about next school year. So there are some proposed changes for next school year with our administrative rules, and I wanted to share those with you. So we're in the process of working on administrative rule changes for our school immunization rules. So these rules have been around since the 1980s. And they've been added to and revised periodically since then. And it is really time for a big reorganization of our rules so that all the pieces of the rules that have been added onto over time can be put in an order that has sections that make sense so that readers can actually find what rules they are looking for. So what we're proposing to do is to repeal all of the existing school immunization rules and replace them with reordered and revised rules. So with that, there's a lot of little changes and wording cleanup that we're doing just to clarify things, make things easier to read. But there are also a few big changes that are being proposed as well, and I wanted to share some of those with you. And just to let you know, we are at the beginning of this process. On Tuesday, we're having a rules advisory committee meeting where we're going to have some representatives from schools, childcares, colleges, clinics, local public health departments, parents, and others to provide some really specific input on some of the big changes and the draft text of the rules. And that's really the first input that we're getting is from this rules advisory committee. There's also going to be opportunity for public comments where we're going to ask for written comments. We're also going to hold a public hearing, and we're going to notice really broadly to all the schools and childcares, local public health. We'll put information on the listserv for providers and put out a public notice about a public hearing so we can get lots of public input on the draft rules. That'll occur likely sometime early next year, but it really depends on how extensive the feedback we get from a rules advisory committee is. As far as how many more revisions we have to do. So I wanted to go through 4 proposed changes that are really a bit more substantial. Okay, number 1, we're proposing to change what's required for documentation of a medical exemption. So right now, a medical exemption requires a letter written by a physician, and it's needs to state the contraindication to immunizations, the vaccines that it's for, whether it's permanent or whether it's something that will resolve, and if so, the time frame. And a physician has to write a letter. Well, we're proposing to, instead of having the physician write a letter, that they can fill out a form instead. We hope that's easier for physicians to fill out, and it will hopefully make most medical exemptions that come in complete and based on a contraindication or a precaution to immunizations. Because what happens now is with a free form letter, sometimes pieces get left out and then they get reviewed and we find out that they're not complete. And so then the parent has to go back and get more information from the physician, things like that. And so we're really hoping this process will make things easier for parents, easier for physicians, and easier for schools to make sure medical exemptions are complete the first time. Okay. Proposed big change number 2 has to do with documentation for history of varicella or chickenpox disease. So right now, our rules require or allow for parent documentation if a child has a history of chickenpox. And that really made sense when varicella first became a required vaccine in Oregon. I'd have to look at the year. I think it was around 2000. But back then, many children in our schools had a history of chickenpox because chickenpox was still a fairly common disease back then. The vaccine had only been around for about 5 years. Now, varicella disease is much less common. And so we're proposing to align varicella with other diseases that we accept immunity documentation for and require that the documentation either be from a lab test or from a healthcare provider who documented the disease, and no longer accept parent verification of varicella disease. Okay, that was change number 2. Change number 3. So we are proposing to move the exclusion day deadline, which is currently the 3rd Wednesday in February. We're proposing to move it to the 4th Wednesday in February. And this will have the impact of letters being mailed 3 weeks before the exclusion date rather than 2 weeks before. So basically, it would be giving parents an extra week to get needed vaccines. So one of the reasons we're doing this is mail in some areas of the state, especially rural areas, is just not as fast as it was several decades ago. And we are really hoping that this little bit of extra time will allow as many parents as possible to get immunizations for their kids, and will be able to have as few people excluded as possible. And then finally, the last big proposal is to change the terms exclusion day and exclusion order to immunization day and immunization order, or some term like that. So we hear every so often that people do not like the term exclusion, that it doesn't convey the importance of having a point in time by which all kids have to be updated on documentation of immunization or exemption. And the purpose being that every child has the opportunity to get updated on immunizations at least once a year. So we hear sometimes that exclusion day doesn't convey that. And then there's also historical trauma associated with the term exclusion here in Oregon, with exclusionary practices against racial and ethnic groups, including historical exclusion laws against African Americans. So this proposal is to move away from the term exclusion and replace it with something like immunization day and immunization order. So those are 4 big changes to the rules. There are lots of small changes. We actually have a draft of the rules posted on our website right now. So I'll go ahead and I'll put that in the chat, and you're welcome to look at that. And then keep your eyes out, because sometime probably early next year, we'll send out another revised draft and have opportunity for lots of public comment on these rules. That is all that I have.
Stacy, that was absolutely wonderful. And thank you so much for, you caught us up on time. That was perfect. We'll save questions for this one as well, although I'm sure folks have some, just to make sure that we get to everything in the agenda. And like Mimi said in the chat, we do have a good chunk of time to have discussion later on. So please do hold on to your questions. We're eager to hear those. With that being said, I'm going to transition over to Jenny McKibben. She's going to talk about the Alert IS replacement project and give us an update on that. Thanks, Jenny. And thank you, Stacy. That was really wonderful.
Hello, everybody. I'm going to share my screen. Hopefully I share the right one. Okay. So, welcome. Let me do one more thing. Okay. Hello, everybody. I am Jenny McKibben. I am the immunization program data systems manager and Alert IIS director. I use she, her pronouns, and I'm excited to share some news with all of you today on our Alert IIS replacement project. All right, so why replace Alert
We're not seeing
IIS?
your screen, Jenny.
Of course you're not. Why wouldn't you be? Let's see. It says that I am. Is that better?
Yes, now we see it.
And you see why we place Alert
Yep.
IIS?
Yep.
Okay. All right. So the first exciting screen was really just welcome. And so there's that. Okay, so why replace Alert IIS? So I'd just like to start by reminding you of why we're even doing this and our immunization program goals for this project. So first of all, we want to replace and modernize Alert IIS while preserving the functionality of the current system. We don't want to lose functionality in this process. We also plan to integrate school off system functionality to include components from the immunization record system. So as you guys all finally know, is IRIS. So we are planning to incorporate that system into the new system. We also are establishing a public facing end user portal. So that way people can access their immunizations without contacting you directly or contacting our help desk. And then also an important piece is to meet our timeline goals. And our current contract with our vendor expires on 12/31/27. So that has been our end date for this project for many years. And we'll move in. I'll talk a little more about that in a minute. I also want to talk a little bit about the project itself, some of our objectives. So we do want to expand our role-based access to immunization records. I talked a little bit about that, about the public-facing portal. But we also want to ensure interoperability with not only our internal OHA partners, but all of you, our external partners, and make sure that system remains the same and easily used by all of our, especially our electronic health record system partners. We also want to ensure that our user interface is compliant with all equitable and accessible processes and technology. So that's a really big push for us as well. As you all know, our current system does not meet those needs. We want to ensure functionality is not only maintained throughout the duration of this project, but is not lost in the duration as well. And then also we want to actively engage community throughout the project. So that is a few things I'm going to highlight next, but we really want to ensure that the requirements and needs from partners are included in this project. Okay. Oops. And so with that, I want to speak a little bit more about what we've been doing with community engagement. We have completed our in-person listening sessions around the state. You can see the places that we have traveled. We have learned a lot in those sessions and are incorporating them into the project. We are also talking about a virtual session, and maybe a couple virtual sessions in the early next year. And also we do have 2 ways for ongoing feedback that I'll share towards the end of this session as well. We have a QR code and an email that we are trying to, we're just starting now to communicate those with all of our partners and show that we are hopefully accessible to all of you for any of your feedback. Okay, the other thing I want to talk about is our working steering committee. I've talked with you about this before. It's another method we hope to utilize for community engagement and feedback. We're currently finalizing the plans for this committee, and we'll share some more soon. We have heard from a lot of you, and we're so grateful. We have a long list of people who would like to participate, and you will all be hearing from us probably at the beginning of next year. We will move forward with that working steering committee. And so today, the news that I would like to share with all of you is that we have an opportunity. And with this opportunity, I'm looking at like this Yogi Berra quote that when you come to a fork in the road, take it. Well, our objective here is to take not the fork only, but both paths. And so I'm going to utilize the analogy of a path moving forward to hopefully explain this well to all of you. And as you know, we will have times for questions at the end of the presentations today. But so what we are doing is right now, we're those kids. Maybe some of us are really grasping hard on that teddy bear. I won't say it's me only, but here we are. We are looking at both of these paths, and we are embarking on both. We are embarking on both paths at the same time. Luckily, it's a nice green grass in between the two, and we can move back and forth as needed. So what our plan is that our current vendor, Gainwell Technologies, has developed a new IIS platform that is being adopted by a few other states at this time. This platform does meet all of the national standards and is like a good starting point for us. And so since they are our current contract, we have a current contract with them, we're able to adjust that contract and go to a special procurement to basically procure this new technology and transition from our current technology to this within a year. So as soon as we are able to move forward and get that special procurement complete, we can move forward to transition to this product. Now remember, we're still doing path 1 at the same time that we're doing path 2. So we know that this new technology meets a lot of our needs, but not all of our needs. And so we are we're being very considerate around the fact that we need more than just this, but it is a great stepping stone, and we're going to take that opportunity. So with that, I'll go into a little more detail about both. So think of these, like I said, as two paths that we'll be going back and forth on, and we'll be very busy, but we'll be going back and forth on these and continuing to work on both. So the first one, path 1, is our original path, and that is moving forward and utilizing all of our community engagement feedback to get the system that we need in Oregon for ongoing. And so with that, the implementation timeline really is remember I said end of 12/31/27 was the end of our current contract. That's been our end date. We know that it's going to take longer than that for this path. It always has been known that it's probably going to take at least that amount of time. And so we are looking at implementation into the year 2028, possibly 2029. So with path 2, what this does is this provides newer modern technology sooner. And so with that, as soon as we get that started, our plan is that this transition timeline will be 2026. Okay, so with that, going back to our original work that we're doing, we've been doing a lot of fabulous work getting information from partners, as well as doing a thorough assessment of our needs for the program as well. So we are currently working with a consultant to document all of our workflows within the immunization program, and are getting a lot of great feedback around what our needs are for the program itself. And then also with that, the big highlights of this is that we are continuing to work on getting the school law functionality incorporated completely into the IIS. And obviously, as we just heard from Stacy, there might be some new wording that we need to do within the project, and that is great because we will definitely do that. And then continue with community engagement and continuing to identify any of those gaps, those functionality gaps that we have currently. And then, so this path with transitioning to the new product is going to be fast, and we're moving on it now. And so what we're needing to do is just extend our current contract and the scope of the contract. And with that, we have just this opportunity to transition to this new modern system, which includes that consumer access portal, which is the access to individual data online. So there will be drastic improvements in this first round, this first path, this first stepping stone. I'm trying to get my analogies all the same, sorry. But the other thing that's nice is that this system is compatible with all devices. So if you use handheld devices in your clinic, you'll be able to access alert easily with those devices, and also will be available in multiple languages. And so we will, as we know more about what this will provide in our timeline, we will definitely share that. I wanted to just point out that we are definitely aware of the impacts of this. There are a lot of positive impacts. Over the next year, we'll be very busy for our program, and we will need to basically speed up our transition plans to train all of our partners on this new system. And it's exciting to have this and to have it something sooner for people to well, just to have something sooner. But with that, we also know that within the next 4 years, we will continue to do that other work and to make sure that we can adapt, we can get the system that Oregon really needs completely. And so, sorry, I'm fumbling over my words, but the things that I really wanted to highlight here is that we will still, in the next 4 years, have an access to an accessible and modernized system, just like we're going to now. But I'd like to say it'll be a system that's more organized, right? More of the meets all the extra needs that we have in Oregon. The downside, which is a possible downside, is that the system that is chosen through the RFP process may or may not be the system that we're transitioning to now. If it is not, then we'll need to do that transition and train partners a second time. But with that, the flip side of that possibility is that it may be the same system. And if it is the same system, then we will just need to train our users on the new functionality. Okay, that's a lot of words. I wanted to just also share this. You can totally scan this QR code now, and what it does is it takes you to a feedback, what I want to say, a survey that actually is dedicated to our regional meetings, and so that will be updated soon. But if you would like to give feedback through that, please do. And then also here's our email address that is specific to the project. So if you would have questions or concerns and would like to talk to us in that way, please do. And with that, I'm going to stop and just thank you for your time, and hopefully we'll get you some answers to questions at the end.
That was great, Jenny. Thank you so much. And a lot of information. You did catch us up on a couple minutes. So are you okay taking maybe 1 or 2 questions now,
Sure.
if folks have them?
Well, if you need to think on those questions, please do ask at the end.
Perfect.
Thank you.
That was a lot of information. Thank you so much, Jenny. All right, next up, we're going to hear from our Mimi Luther. She's going to talk about Project Horizon and service prioritization. Mimi?
Thanks, Julie. Hi, everybody. Mimi Luther, I use she, her pronouns. I'm the section manager for the immunization program. And I think this might be the biggest meeting we've had in many years. So thank you all so much for being here. Project Horizon, I will be talking about this a lot, so I want to make sure people know what it is. It's the name for the work that we're doing right now to measure and prioritize our services. So some of you know that by June, we will lose about 44% of our positions, of our staff positions. We, with the COVID money going away, we will lose those positions. The work isn't going away, however. So Project Horizon is the method we're using to examine, measure our key objectives and responsibilities, and to figure out what this program is going to look like after June of 2025. We know that there will be cuts in services as well as staff. We just don't know yet what those cuts are going to be. And we're in the throes of figuring that out right now, documenting all of our services and getting ready to prioritize them and make some very rough decisions. And I want to add that, like Jenny, there was 2 paths. Project Horizon has 2 paths to One is the work of figuring out what services we'll be able to maintain next year, and the other is some services that we are offering to our staff to make sure that our staff is well cared for, and that we're taking good care of each other in this really difficult place. And I think I'm just going to leave it at that. I'm sure we'll be talking about it more in the discussion section, Julie. So unless folks have quick questions now, we could swing into Kelly.
Okay, I'm pausing for quick questions. All right, I think we're all on board for doing the questions during the discussion time, so we'll just move to the next one. It's my pleasure now to introduce Kelly McDonald, who's going to talk about vaccine finance reform and the steering committee. Kelly, it's all you.
Hey, everybody. Thank you. I'm a little bit out of breath. Had a delivery. Somebody was just ringing that doorbell over and over, so I had to run down and get it real quick. But happy to be back with you all today. Over the past year or so, I have provided updates, I think, at just about every meeting on our vaccine finance reform work. And I'm going to share a slide deck and just give you an update on where we are right now. Give me just a second to share. Okie dokie. That does not appear to be. Is that working? Julie, can you see that?
I can now.
Oh, great. Okay.
Perfect.
Okay, that should be good to go. Okay, so I'm here to provide an update, and I'm going to go over some background just because I know we have new folks and just to sort of level set the context of what we're talking about. I've spent a lot of time at this meeting and in other meetings that many of you have attended talking about our outdated finance model. It is, 3 decades old. It's fragmented. We have this patchwork of programs that are designed to ensure access for specific groups of people. So based on age or insurance status, that we have specific vaccine for different groups. And of course, along with that means there are different requirements, and it has gotten to be administratively burdensome and expensive to manage that program. It's burdensome for immunization providers for sure, and also for OHA. We in the immunization program, I think, are often trying to make a broken system work rather than being able to be sort of innovative and as sort of, forward driven as we would like to be. Vaccine costs are increasing rapidly. I've shared as well just that, significant cost increase over the recent years. We've had a lot of new vaccines and new technology available, and that is really fantastic for disease prevention. And it has also meant strained budgets. And so that is a challenge. As Rex shared earlier, we are seeing some decreasing immunization rates, also very concerning after several years of gains. And we're just particularly concerned that this growing complexity and cost for immunization services has hindered improvement efforts to bring those rates back up. We know that many small and rural providers find it difficult. They find it cost prohibitive to participate in the VFC program. The Vaccines for Children program requires that enrolled providers, purchase and maintain a separate stock of vaccine for their privately insured kids. And, for providers that have a small patient population, but still need to purchase that minimum, required amount of each vaccine, it's extraordinarily expensive and it can be cost prohibitive. And for sites like that, it would be ideal to be able to offer enrollment into our vaccine access program. That program was developed in the early 2000s to support safety net clinics being able to serve anybody who walks through their door with mostly one stock of vaccine that they can get from us. And so, if we could allow these, small providers who struggle to enroll in VFC, if we could allow them to enroll in VAP, we could help. But because of the challenges that we have with costs, without additional funding for that program, we are not able to do that. And I'll talk a little bit later about the pause that we have on our VAP program enrollment. In fact, just yesterday, I learned of a naturopathic clinic that was interested in enrolling in our program. They were provided information about VFC. That was cost prohibitive, not able to do that, but they really want to offer vaccines to their patients. VAP would be a perfect option for that clinic. But again, we're just not able to expand right now, and we're actually in danger of severe cutbacks. And of course, the challenges exacerbate existing disparities in vaccine access, particularly for our low-income populations, for rural communities, and historically marginalized groups. And so for the last 18 months or so, I've been talking a lot with providers, with partners throughout the healthcare system about these challenges. All of that culminated last January with our Vaccine Finance Summit. We held that in Portland. It was a day-long event in person, and we had presentations and panel discussions. And ultimately, it was very obvious that there was support to continue these conversations, that folks felt like, the challenges that they heard talked about from different participants really resonated with them, and that they wanted to be part of the solution. And so the result of that was the formation of the Vaccine Finance Reform Steering Committee that was tasked with developing a framework for a new model, and really specifically to look at how to reduce barriers for immunizing providers so that they will offer immunization so that they can roll in our programs, and to support equitable access across the state. And so our multidisciplinary steering committee, we had 26 members from across Oregon's healthcare system. I think my next slide has some more information about who all was, what organizations were represented. And we had an initial meeting, introductory call in May, and then the group met twice per month through September. The group delivered a report and recommendations to OHA on September 30th. I'll share those in just a second. And then the steering committee has a subgroup now that has formed that is doing the advocacy work around their steering committee recommendations. So they have met with legislators and OHA, and they're doing the work to move their recommendations forward. Our steering committee members, as I said, we had representation from across the system, from local public health, from provider associations, large independent practice associations. The Office of Rural Health was there. We also had representatives from both private payers and from CCOs, and OHA, fee-for-service represented. We had federally qualified health centers, hospitals and health systems, and advocacy groups as well. We also had industry represented through the Biotechnology Innovation Organization. So getting to the recommendations, I'll draw your attention particularly to the second and third bullet, that a formal work group be established to consider options to address challenges with the current vaccine finance model and related impacts on access. And that specifically they further evaluate and model out a universal vaccine purchase program and what it would look like to fully invest in the current programs, with a report back to the legislature by 2026. So during the course of the steering committee's work, they talked through and worked through multiple different recommendations and potential solutions. It became clear after time that, some would be eliminated for various reasons. And it really came down to these two particular options. What would a universal vaccine purchase program look like in Oregon? Is that feasible? And if not, would it make more sense to fully invest in the current program? So those are the two items that the steering committee would like this formal group to pick up and continue to model out and evaluate. They were very clear with their recommendations that this would not be a starting over. This is picking up from where they left off. And then importantly, the third bullet is that there would be additional funding directed to the current programs so that we can maintain and expand our provider participation until that formal recommendation is made and those recommendations can be implemented. So what's next? This small steering committee group has worked through their own government relations channels to share the report and the recommendations with legislators. They have met in late September, met with Senator Deb Patterson and submitted a placeholder bill for recommendations 2 and 3. So that group is continuing to work with legislators and legislative council to draft that bill. Steering committees will continue to track and support the work during this session. And we at the immunization program have contracted with the University of Washington's Northwest Center for Public Health Practice to do a provider assessment. There are several different components to it, but ultimately to have some data that we can use to demonstrate barriers for participation in VFC and in our vaccine access program. So often it would come up with the steering committee questions like, you talk about clinics who are on the cusp of disenrolling because the barriers or the costs are too high. How many clinics? How much of a burden is it? What percentage of clinics, for whom do you think that the rising vaccine costs is too much of a burden? Things like that. So we want to have some more concrete data in addition to all of our anecdotal reports. And then really importantly, I just want to stress that we are pausing our vaccine access program enrollment. We are doing that to find out, what will happen with any potential funding going into this next year. And we're making plans to potentially offboard a significant number of providers from our vaccine access program. If we don't have additional funding to support that work, we have to change the current structure, which will unfortunately mean scaling it back significantly. Certainly happy to take questions about that when we're done. And then just to put a fine point on it, our concerns around the consequences of inaction, so that if we do not find a way to reform our current model, the access will continue to decline. And we know that some folks will be disproportionately impacted by that, particularly our rural, our uninsured, and our historically marginalized communities. And I thank you. That's my contact information. And I should note too that there were several members of the Vaccine Finance Reform Steering Committee that are also IPAT members. So we had a nice overlap, and we have a nice overlap for this discussion of several members who sat on the steering committee and are also on IPAT. So I'll close it there and pass it back to you, Julie.
Kelly, thank you so much. Another very full presentation and nice recovery after running beforehand. That was very impressive. Thank you so much. All right, I'm going to turn it over to Mimi Luther now.
Okay, this is the time. Everybody, Kelly, thank you. And thank you, everybody. That was just so well done. I am going to turn it over to discussion time as soon as I can figure out how to share my screen. It's not my forte, Okay, let's see if this works. And I'm going to encourage people to please come on camera if you are comfortable doing that, and help each other feel comfortable asking questions. We're ready for them. Julie, can you see my slide?
Not yet.
How about now?
Still no. But you're doing it.
Now you see it?
I wish.
I'll shoot it over to you. It's not essential, but I'll shoot it over to you in chat, and maybe you could put it up for me.
Oh, that's cool. We'll see. Okay. I'll give it a go for sure.
I see a couple people came off. I see Dr. Braun did. Let's have a discussion. Help us get through what these next 6 months are going to look like for us, because it's going to have such a huge impact on you and those people that you serve. So Mimi out, I'm in listening mode. Who wants to go first?
And this is Dr. Alana Braun. I'm a general pediatrician, and I use she, her pronouns. I represent OHSU Pediatrics, and then also I'm on the board of the Oregon Pediatric Society, and I was on the steering committee. And I guess, if anybody has additional questions, I know there are a few of us on here, and I've been on the sort of small group who's been working with Senator Patterson's office. With some really wonderful leadership from the Oregon Families for Vaccines group. So I think at this point, our hope is that we can sort of get some more formal input. I think there were too many potential models and too many details that we just didn't have time to sort out as far as coming up with a model in Oregon that would not negatively impact our current systems. And so, the hope is that we can come up with something and do a little bit more modeling to get vaccines to kids in Oregon and support places that are having a hard time while not sort of hindering efforts in places that sort of already have it down and do high volume vaccination. Because I know a lot of the pediatric practices were concerned about some impacts of, some of the potential universal purchase models. I think at this point, sort of asking our smaller team, like, what do we need from people? I don't know that we're at a place quite yet where we have the legislative concept, and Senator Patterson's team is working on getting that written up with the Oregon Families for Vaccines team. And so we don't have a bill number yet. I think once we get that information, we'll be able to sort of ask people to start chatting with legislators. But for now, if folks are interested in sort of staying on top of this and learning about more and sort of advocacy opportunities related to that, the Oregon Families Vaccines group will be pushing out updates. You can sign up for updates through their organization. You do not have to sign up as a parent. I think, anyone can be a family for vaccines, but that's the best way to get information about that. And I'll put their link in the chat.
Thanks, Dr. Braun. Anybody else want to chime in? Or what I'd really love is for folks to share ideas on how you all can do what we cannot do. And that is to inform your communities, inspire some advocacy and action. And to do that in this room so that other people can get ideas from each other on how you can get involved.
This is Deborah. I'll go ahead because I raised my hand. I just wanted to say that the OHA team did an outstanding job in really looking at all of the different options and researching the information. And I think that, I know, as you all heard from Mimi, that we're at a really important place with the Oregon Immunization Program and the vaccine programs that we're offering, that something that needs to be done. And so I want to say that this work is not taken lightly, and that the teams have done a lot of great research, and it's such a complex area that clearly there's more that needs to happen. But I myself am nervous from what I continue to hear from Mimi about what's going to happen, not only with just the state of the current financing, but in June. And I don't know that is quite realized by those that make decisions. And so I think it's important for the group to make sure that they understand, what's happening and how we can continue to support in this important area, especially with the challenges that we're going to be faced with in this change in administration at the federal level. I think that we're all going to need to be doing something different and figuring it out along the way, and reduction in staff is not the way to go if we want to improve access. And so one, I wanted to applaud the team, and two, I do think that we need to continue to figure out how to alert those in charge of what's, you know, what the potential consequences will be of inaction. Oops.
Thanks, Deborah.
And if I may, I'll just add too that, you know, I am available to groups, to clinics, to, you know, clinical teams, to any of the groups that you represent, to share sort of the bigger, you know, vaccine access piece, like to really walk through our finance model, what it means and how it impacts, how the challenges impact access around the state. So if you feel like you want or you need a deeper dive into that, or you want that shared with your groups, please do reach out. I'm happy to schedule time for that.
It's also a good time for any other questions. So Rex shared what I like to call the program's best kept secret today, and that's the beautiful Tableau work that his team has done. Feel free to ask questions of Rex if you want to know how you can access data. If you have questions for Jenny about the IIS replacement project, all questions are open. We really want to hear what you're thinking and what you want to hear from us. Yeah, those graphs are great, aren't they? It was our best kept secret. It's not anymore. School law, what do you think about Stacy's? Lisa, I know you wrote in the chat and you don't have a microphone, but what do you think about the proposals for school law? We're super interested in hearing from you.
I mean, it's Deborah again. I don't mean to be the only one to talk, but I think that it's great that you're refreshing the laws. It sounds like they need to be refreshed, and I especially appreciate representing many pediatricians. I especially appreciate the streamlining those processes. I think that anywhere we can help reduce the administrative burden for the provider practices, I think that that's great, and especially when it on such a potentially contentious topic in many places with school exemptions, but something that's just the bread and butter of providers and what they do every day. So I really appreciate that streamlining in the form, and it will help on administrative burden on both sides, on the provider staff side as well as the Oregon immunization program. So I applaud the work that you guys have done to try to do that, as well as streamline those regulations.
Great. Thank you for weighing in on that. Yeah, good work. Really great work. And gosh, I don't know how many of you have ever had the opportunity or experience of overhauling a set of administrative rules and statute, but it's a lot of work. Teresa knows. Yeah. Anybody who's worked for the government has some clue. And Julie, we don't have to hang out. We can let folks go early if questions aren't forthcoming.
Okay. Did you have
This is
something?
Deborah, I have one more question. Sorry, on each of those topics. Am I okay to go there?
Absolutely. We do have time.
With Rex's last set of slides of just the questions of how are we going to approach, it's going to be an interesting 4 years, and I'm really nervous about that. And how do we balance the already declining rates with potentially increasing skepticism, and how we balance that with where all of the things we know to do to beef it up with incentives, but there's going to be a lot out of the control of many people. And so I'm just curious of how we can, as a state, support the potential increase in skepticism or hesitancy, I'll say, with vaccines as a state, because it needs to be an all-in effort, but also something at the higher level too, in terms of public campaigning and really helping to make sure that we're sharing the benefits of vaccines. And so I think Rex was starting to lead to those questions, and I know nobody has answers about that right now, but it's something that's really on my radar and something I'm really concerned about. And how do we watch that and monitor that impact? Actually, and the dashboards will be a great way of like real-time impact on messaging that comes from the top. It's not so more just, I think we're going to need to be on top of that in the near future.
Rex, do you want to respond?
Yeah, I mean, I think I asked that question of IPAT because I know that we're all so involved with immunizations, but at many different levels. And in Oregon, we don't have a system where the state has a particularly strong hand in immunization administration, right? We rely heavily on local partners, on local providers and local public health departments. And so I think, as you said, it's definitely going to be an all hands on deck effort to shore up the system in the coming years. And I think there will be, threats from many different places, and certainly places where we wish that we were getting support from. And so I think IPAT is a place where we can start to develop that long-term planning on how to address some of this. So hopefully there'll be more discussion here in the future on it. But you're right. I think at this point, none of us know what to expect and what the years will bring.
Kind of related to that, I guess, I think I'm still sort of processing some of what we've learned today about our existing infrastructure and, the cuts that are going to be made, and sort of thinking about that, and also thinking about our declining vaccine access and vaccination rates. And it's so worrisome. And so I guess I'm wondering then, is there some data that we can sort of have or share looking at some of those potential impacts? And then what is the best way to where are these decisions coming from, and who do we talk to? Who do we ask to help us make this better? I don't know. Maybe I should know this, but if you could share, that'd be great.
It's okay, Alana. So, the immunization program, we're officially neutral when it comes to anything political, including the legislation that came out of our own work. But there are places that other people can go, right? You certainly can talk to each other, right? Because some of you are represented by agencies that have access to legislators, and can find out more. You also can have people ask us for more information. If you want more, let's say, that the program is going to lose staffing, local public health authorities are getting more constrained in their capacity, rates are going down, disease is going up. If that formulates a question for you, you can ask us that and we can produce that data for you. And the same is true for anybody that you would talk to about this. Deborah, you're in the private sector. Can you talk about where people can go? Or ideas on what people who are worried right now should do with their worriedness?
I don't know yet. Excuse me. I mean, we have different levers. We have, partners that are engaged with the CCOs who are also held to some very high standards related to vaccine rates. I think that some of that conversation could come up in, even some of the state's very ambitious goals of vaccine rates and how we look at that, but that's not a solution or funding for the program. There's several groups that I think do have lobbyists, and many of them are on the call now, that are talking to legislatures. But I think for the immediate concern, I mean, perhaps there is ways to just tie in some of that discussion with the vaccine finance reform work, and because people may not be aware of that complete picture. And providers, they continue, I mean, this is what they do. They continue to have those conversations. And I think it's a challenge with some of the shared decision making that they want to make sure that they're bringing the parents and, into the decisions. And I think many of them got gun shy during COVID with a lot of the hesitancy and pushback.
Yeah.
So I don't think that's going to cease, but it will be interesting to see how, what the reaction is, on the one-to-one interactions. And Alana might have, a better, visibility into those interactions and what they do at the clinic. I don't think they'll change. I think they'll continue to promote immunizations, but they clearly need extra help.
Thanks. I do think, Alana and everybody, that the ask I have of you is to share what you learned today with the community that you represent on iPad. So Jen, you represent naturopathic doctors. If you can find an avenue to share this information, because the more the key folks are aware, the better the chances are that somebody's going to help put together a solution, or at least a plan for how we're going to survive until things are easier for us. So reach out to people you represent. If you need talking points or graphs or anything, reach out to us.
And Mimi, I know that you say that you have to be neutral, and a lot of it's driven by the budget with OHA and perhaps governor's priorities too, outside of legislation. Is there anything there that that needs to be elevated that isn't currently, or is there any opportunity there as well?
It's still pretty early. The governor's budget just came out and we're all talking about it and digesting it. So I think you'll see some clarity and change in the next week or two. Somebody just asked if people in the room who aren't voting members know that you can ask questions. If you don't, yes, please feel free to weigh in and ask us questions. You don't have to be a voting member to do that.
Thanks, Mimi. I was trying to figure out how to unmute my phone. The Zoom on my phone, I was really struggling there. I think I wanted to just say, as a naturopathic, I'm Jen Gibbons, I'm a naturopathic doctor, and I in private practice in Portland, and I was one of the very early vaccine access program enrollees once it was expanded. And to say it was transformative for me is really understating. I was really at the point where I was going to have to stop vaccinating because I couldn't keep up with the pricing and the cash flow crunch that having to purchase a separate stock of private vaccine was creating for me. And I'm definitely someone in my community that gets a lot of calls from my colleagues asking how to do vaccines, because everybody knows I vaccinate. And I'm having to tell all of these newer clinics or clinics that are trying to add vaccine to their practices that that there's really a long waiting list for the vaccine access program. And there's a lot of NDs that really want to vaccinate, and they cannot afford to vaccinate because they cannot afford the cost of those of the private stock. And there's such a hunger there.
And we know that
Yeah.
those folks won't go, and the folks that you serve aren't going to go somewhere else to get vaccinated.
They really don't. They
Yeah.
really don't. And the thing that I really learned was, when I only carried a handful of different vaccines, suddenly the patients really only, kind of air quoting here, wanted those vaccines, right? And then as soon as I carried all the vaccines, like the rates of my meningococcal went up, my rate of HPV went up, rotavirus went up, because I have them available. And there's a bias there that if you're not carrying those vaccines, the patients don't think that they're important. And so in these little clinics where we are struggling financially, if we can get vaccines into them, the vaccine rates will go up. They just do. And so figuring out a funding model that does get the vaccines into the small clinics, which includes the NDs who do see a population that will not go elsewhere. And I've had people come in who are staunchly, I hate to use the term anti-vaccine, but staunchly declining vaccines, who now have their kids fully vaccinated because we built trust over years and we started going, and now they've caught their kids up. And so I do think we have to find a funding model to keep vaccines in these small clinics. It's just vital to me.
You are really good at this, Jen. Thank you. You get
Yeah.
the fire going, for me.
Yeah, well, it's something I feel so passionate about because
Yeah.
I really, if the vaccine access program goes away, I don't know what I'm going to be able to do, right?
Yeah.
Like, it's very real. And I feel so passionate about having the vaccines in the clinics because the patients will do it if we have them there.
Sort of like if you build it, they'll come.
Yeah, but it's true. So
Yeah.
thanks.
Thank you. Thank you so much. Lisa. Hi.
Is my mic working now? So I am a communicable disease nurse with Lane County Public Health, and I've been around for 11 years now. And my level of anxiety is very large. Not only, I mean, Lane County currently is in the middle of pertussis, and I think we're leading by over 100 cases in the state. And we've been doing it since March, and our team keeps shrinking. And so I have a lot of anxieties moving forward, not with the unknown of what is going to come. And I've also just seen a huge decline. I mean, public health has always been the safety net, and we can only catch so many people. And I feel like our safety net is also getting smaller and smaller as all these funding goes down. But just not knowing what the future is going to hold and what insurance is going to look like. I fear like our net isn't going to be wide enough to catch all the people that might be losing services. And, for the NDs and the small clinics, like they might not have the capacity to fall back on public health that we've always been here as a backup. And so, yeah, I'm just echoing everything that everybody's already feeling. But from a public health perspective, I'm also just really anxious.
I'm really sorry about the anxiety, Lisa. And I think what you just said makes me realize that, you making sure that your administrator knows what's coming in terms of access to immunization services, that's a big help. They're as busy as everybody in this room, and getting that information in a packet of lots of other information, people are going to lose it. They're not going to understand the real threat that this creates to public health. So if you can share the news. Yeah. Kelly, the yellow thing on your background keeps making me think you have your hand up. Teresa,
Sorry.
it's okay.
I should move over this way.
Yeah, I thought it was a hands up too. Yeah, I guess the only thing that I would dovetail on Lisa's comments with is the more of these outbreaks that the CD teams are needing to deal with, like the less attention they can focus on each. And sometimes that means like individual cases they might usually support, or if there's a small cluster they might usually support, they might not have time for, which is very reminiscent of COVID and the stress and moral injury we had in COVID when we couldn't do the things that we really wanted to. So we're also feeling that stress really intensely in our public health neck of the woods.
Okay, everybody. Let's call it a day. Thank you so much for being here, and for chiming in and for listening and for anything you can do moving forward. We will come up with a plan for what our program's going to look like. We'll share it widely. We're working very hard to be clear on how we do that, make those decisions. And how we absorb the work of 44% of our staff. And what will have to stop in order for the people who will still be here to still have a workable, healthy job, work, home. Yeah. All right. Let us know if you need anything. Thank you, everybody.
Thanks, everybody. The next iPad's going to be in March, and we look forward to seeing you there. Thank you, everyone, so much for coming. Really appreciate it. Have a great rest of your day.